specifically about cancer genetics. So all of the genetics that go into cancer, and this is because I just got done with my first clinical rotation of genetic counseling school, and that rotation was in, you guessed it, cancer. So I was seeing patients for all sorts of cancer-related reasons, mostly like people that have cancer or have a family history of cancer, and getting some genetic testing done related to that. So we're going to talk all about that and some common cancer syndromes and just like things that I saw over my month in the rotation. So really excited about it. Yeah, so let's get started. We're gonna talk first about like what cancer is and how cancer comes about, and then how that plays into like hereditary cancer and stuff like that. So I hope you enjoy. I don't claim to be an absolute expert. I think I'm kind of an expert in like explaining to patients how hereditary cancer works, but like not an expert on everything. So we're gonna start with a graphic that I made for a previous Teaching You Genetics video, and it is of the cell cycle. And I think this is just important for kind of starting to explain like how cancer happens. So you probably know, or maybe from my previous video, that the cell cycle, all of your cells are going through this, and it is what they do to divide. So your cells are constantly dividing and creating new cells. And to do that, so the cell will grow here, and then its DNA replicates. So all of your cells have a set amount of DNA, and in order to divide and replicate, they have to replicate that DNA first. And once the DNA replicates, it grows some more, and then the cell divides, and you get 2 new cells. So that's like the basis. But I did draw on this picture before these checkpoints. And so the checkpoints are essentially like making sure that everything is going properly in that growth and replication process. And so, for example, like down here, if a mutation occurs in replicating that DNA, if something goes wrong in replicating the DNA, the checkpoint is where that cell, your body will be like, this cell is bad. We need to get it out of the cell cycle and kill the cell because the DNA is not replicated properly. It has a mutation. And so that's what happens normally, is your body kicks those cells out and prevents anything bad from happening. But what's happening in cancer is that those mutations are going unregulated. So the mutations are happening in your DNA. It happens in all of us. It's just that when cancer happens, the body isn't destroying those cells like it should. So that's leading to uncontrolled growth and leads to those tumors that can spread throughout your body. I hope that makes sense as like a basis of how cancer happens to begin with. So kind of the main tagline here that we always say in cancer genetics is that all cancer is genetic, not all cancer is hereditary. Okay, so all cancer by definition happens due to genetic mutations in your cells, like I just explained, but only about 5 to 10% of apoptosis means cell death. It's the process by which your cells die or are killed. If they are old or they're not working properly, they get killed. But cancer cells don't do that. Cancer cells proliferate and replicate endlessly. They're literally able to just continue replicating, and that's a problem. So they are evading that apoptosis that's supposed to kill them. They are continuing to proliferate without any checkpoints, any stops in that process. And that kind of goes along with the replicative immortality. So I don't know if you guys have heard of telomeres. It's essentially the ends of your chromosomes. So I would have to go into everything about DNA replication to explain that, but the ends of your chromosomes, the ends of your DNA, have these repetitive sequences, and essentially what that is because when you replicate your DNA, there's a little piece at the end that isn't able to replicate itself, and so that little piece has to be discarded. And so our body evolved telomeres on the ends of our cells, which are basically sequences of DNA that the body doesn't need. It's not part of your genetic sequence. And so when the ends can't be fully replicated, it doesn't matter that we're just getting rid of that telomere. Whereas if we get down to the end of the telomere, we can't just start getting rid of our DNA sequence, if that makes sense. So that the length of the telomere essentially determines the lifespan of the cell. And once you get to the end of the telomere, you can't continue replicating. Well, cancer cells maintain their telomeres forever, and so they never aren't able to replicate. It's actually kind of interesting because cancer cells might actually hold the secret to anti-aging and determining how to make our cells live forever. So cancer cells are really bad, but they have figured out how to replicate forever, which could potentially be the secret to anti-aging. I don't know. Research. Another thing cancer cells are able to do is to induce angiogenesis, which basically means they're able to create their own blood supply so that they feed themselves, because cells need blood to grow and what's the word I'm looking for? Prosper. I don't know. They need blood, and so cancer cells are able to induce angiogenesis and essentially get blood supply for themselves. And then they are also able to invade other tissues and metastasize. So normally your liver cells could not just leave the liver and go grow in your brain. Can't do that. But cancer cells, if cancer cells start in your liver, these mutations make those cells so irrecognizable from what they originally were, and those cells are able to leave the liver and go travel in your bloodstream and take up camp in your brain. And that's kind of how cancer metastasizes from organ to organ and evolves into a stage 4 cancer. So those are kind of the features of all cancer cells, whether the cancer was hereditary or not. Yeah, I think that's kind of a basis of how that happens. And we're going to talk about some of the genes that are associated, the types of genes that are associated with cancer. And again, we're still kind of talking about all cancer. So these genes are implicated in all cancer, but we'll start talking about how this can be hereditary. So there are two main classes of genes, I guess, that are associated with cancer. And so the first are called proto-oncogenes. So we all have proto-oncogenes, and they're important for our cells cells and making them divide, which, kind of like we talked about, is something that we want to happen. We want our cells to divide and grow. So if both copies of our proto-oncogene are working normally, we've got normal growth, a moderate amount of gas pedal, we're pushing normally on the gas pedal, causing our cells to grow, and that is good. If you haven't seen my other videos or you don't know much about genetics, we get 2 copies of every single gene in our body. One comes from our mom and one comes from our dad. So every gene, we've got those 2 copies on 2 separate chromosomes, and that's just what that is showing, is that we have 2 different copies of that proto-oncogene, which is colored green, one of the genes on the chromosomes. But what can happen in cancer cells specifically is that we get a mutation in one of those copies of the proto-oncogene, and so that's here where the mutation is red and the normal copy is still green. And when we get a mutation in it that causes cancer, we call it an oncogene. And so proto-oncogenes are normal. We don't want oncogenes to be functioning. So essentially, if we get a mutation in one of those genes, that drives cancer cells. It drives cells to uncontrollably divide and not look back. So it can be due to having a mutation that causes too many copies of that proto-oncogene to be produced. So like, if one oncogene causes normal growth, having 10 copies leads to way too much growth. Or it can have mutations that make it active all the time. So like, rather than the gene shutting off when you don't need your cells to divide anymore, it is active all the time and it just keeps making your cells divide. And so having a mutation leads to overgrowth. The important thing here is that with oncogenes, you only need one mutation to lead to cancer, and that's essentially because these mutations are a gain of function. So like, if this gene is making cells grow normally, but this one is making them grow like crazy, the cells are gonna grow like crazy. Like, you only need one mutation to drive that growth, if that makes sense. These are some examples of oncogenes: RET, EGFR, ALK, and KIT. For the most part, these are not mutations that you inherit in your family. So these are those mutations that happen sporadically. They happen just in cancer cells. In anybody, we can find these mutations, but they're not mutations that you were born with that cause cancer. We will talk a little bit more about the RET gene later and how that's associated with some hereditary cancer, but for the most part, these are mutations that happen just in sporadic cancer. Down here, we have our tumor suppressor genes, and this is the big thing that we're talking about with hereditary cancer. So, as opposed to the proto-oncogenes, tumor suppressor genes' job is to essentially not stop cells from growing, but regulate the cell growth. So these genes are responsible for either repairing our DNA, like if a mistake or mutation happens in our DNA in the cell cycle, they're responsible for repairing that DNA or removing the cell from the cell cycle, inducing that apoptosis or cell death. So these are kind of like the brake pedal. They're like the brake pedal that keeps cancer from developing, as opposed to the gas pedal of proto-oncogenes, if that makes sense. So when you have 2 working copies, 2 green copies of a tumor suppressor gene, we're all good. We're still going to prevent those cancer cells because we have 2 working copies. said, if we're pressing on the gas really hard, it doesn't matter that we have a normal copy. We're gonna replicate and create a ton of cells. If one of our sets of breaks fails, but we still have another break, we're okay. We're at risk of potentially that other set failing, but we're okay. We can stop cancer cells. So having one mutation doesn't really affect things. However, having two mutations, so both of these are black, which inactivate both copies of a tumor suppressor gene, now we can't prevent those cells from replicating like crazy and causing cancer. So that's why with tumor suppressor genes, it requires both to be inactivated. With proto-oncogenes, only one needs to be overactivated to lead to cancer. So this is most of what we're talking about when we're talking about hereditary cancer, is that sometimes people are born with an already non-working copy of one of these genes. So they're born right here. And so rather than needing two mutations, one in each copy to lead to cancer, they only need one more mutation to lead to cancer. And so that's why people that inherit one of these mutations typically get cancer at earlier ages, or they get specific types of cancer or similar types of cancer running in a family. I hope that makes sense. This is how most of us are born, and two mutations can still happen. We can still acquire two mutations, and that's why 90 to 95% of cancer happens without being born with any mutations, because this can still happen. It's just that if you're born with one, you're halfway there. You're halfway, and so you're gonna get cancer a lot earlier, or specific types of cancer. So I think that's everything I wanted to say. Oncogenes are like slamming your foot on the gas. Tumor suppressors are like all of your brakes failing. That's the, yeah, analogy, I guess, that I have for that. Okay, so I think that explains all of our basics of cancer. And now we're gonna get into the stuff that I really like and what I've spent my whole rotation doing, and that is like taking somebody's family history and assessing if we think that maybe there's a hereditary cancer predisposition or mutation running in this family, or if it looks like something that is more sporadic. So before we get into that, I think it's helpful to explain how common cancer is and what types of cancers we aren't really concerned about being a hereditary risk. I think a lot of people come to us and they're like, I've had 3 relatives with cancer, there must be something inherited in my family. And then we draw the family tree, we learn what types of cancer those were, and we're like, okay, we're actually really not concerned at all about this family. So kind of teaching you guys that stuff. So cancer happens all the time. Unfortunately, it is very, very common. It happens in like a half to a third of all people. And like I said, only about 5 to 10% of cases are actually due to an inherited mutation. So cancer can be due to lifestyle factors, other risk factors. The main factor with cancer is age. As you get older, you are exponentially more likely to get cancer, and so it's not uncommon to see cancer at older ages. Talking about some of those specific risks, some of the most common cancers we see are breast cancer and prostate cancer. Both breast cancer and prostate cancer, about 1 in 8 men and women respectively get those. So men have like a 12% risk of prostate for the most part it's due to sun exposure. So those are super common, but we're not super worried about them. Ovarian cancer and pancreatic cancer happen in about 1 to 2% of people. So on the rarer side. And so when we see those, we're more suspicious of something hereditary. Colon cancer happens in about 4 to 5% of people. Uterine cancer happens in about 3% of people. Trying to think about other like common cancer types. Pancreatic, ovarian, uterine, colon, breast, prostate are kind of the big ones that we talk about in cancer genetics. And then cancers that are just, we just don't know of really any like hereditary basis for them, so we're not really thinking about them in our risk assessment, are liver cancer, like oral cancers, lung cancers, throat and esophageal cancers, cervical cancer. Cervical cancer is typically due to HPV infection, so we're not really thinking about that. But yeah, so that's like basics. And now we're going to talk about what makes us more suspicious in a family that there might be something hereditary, that we might be looking at a hereditary cancer predisposition. So, features of hereditary cancer. The first one is multiple relatives with the same or related cancers. We'll kind of touch on the related part later when we talk about specific syndromes, but same cancers, like obviously 3 or 4 relatives with breast cancer is pretty concerning for something being hereditary. The kicker there is that those relatives need to be on the same side of your family. Those relatives need to be related to each other for that to be a significant increased risk. I can't tell you how many times I've had people come in and say that they have a really strong family history of breast cancer, and when we draw the family tree, it turns out that it was their maternal grandmother and their paternal grandmother that both had breast cancer. Well, that's unfortunate. That maybe increases your risk a little bit, but your 2 grandmothers are not related to each other. There's no way that there's something hereditary that they passed to each other because they're not related. So it's kind of like saying, well, my grandma and my friend's grandma both got breast cancer. Like, those don't have anything to do with each other. They're not related. So we're looking for similar cancers in people that actually share genetic material to look if that might be hereditary. The next thing is a high affected to unaffected ratio. And so what that means is a greater percentage than what we would expect if it was just sporadic cancer. More people in a family affected than what we would expect. And an example of this is like if you have 2 sisters and both of them got breast cancer, that's pretty concerning. 100% of your sisters got breast cancer, which is a lot greater than that 1 in 8 that would be expected. However, if you have 12 sisters and 2 of them got breast cancer, you still have 2 sisters with breast cancer, but that's only 1 in 6 of your sisters, which is maybe slightly more concerning than normal, but not as concerning as if those 2 sisters were your only sisters, if that makes sense. So like sometimes we take family trees and somebody has like 10 siblings and 14 aunts and uncles, and then we get a pretty good picture of like, okay, you only have like 3 people out of those that had cancer. That's pretty expected when you have that many relatives, whereas someone that has a really small family tree, you know, Next is younger ages of diagnosis. As I talked about, cancer is super common. Age is the biggest risk factor for cancer. So seeing breast cancer at like 70, 80 years old, not extremely concerning. Typically, if you were born with one of those inherited mutations, most people get breast cancer in like their 30s or 40s. So typically looking for younger ages of diagnosis. Absence of known environmental risk factors. Essentially, environment is not hereditary. So like when someone says their family member had lung cancer, I always ask, were they a smoker? If they weren't, then maybe we're looking at something concerning. Whereas if they were, we can say, okay, that lung cancer is probably due to that smoking. So absence of hereditary factors is when we're maybe looking, or environmental. Absence of environmental is when we're maybe looking at something hereditary. Rare cancers, that's a big one. So like I said, breast cancer, prostate cancer happen in a ton of people. Not super crazy to have a couple family members with those, but rare cancers can be more indicative of something hereditary. Ovarian and pancreatic are relatively rare, more likely to be hereditary. Even things that are extremely rare, like male breast cancer in a man, pretty indicative that there might be something hereditary. Also, like rare tumor types, so we'll kind of talk about paragangliomas and pheochromocytomas. Big words, but like rarer tumors are more likely to be like something hereditary, especially if multiple family members have them. Next is multiple primary cancers. This means that in the same person, they got multiple different cancers. So like having breast cancer in their 30s and then having pancreatic cancer in their 50s. Multiple primary cancers. That doesn't mean that one spread to the other. That doesn't count as another primary cancer. Presence of other non-malignant features. This applies to like specific syndromes. So some cancer syndromes, not really like what we're going to talk about today, I guess, but some cancer syndromes are associated with like colon polyps or like skin features, like bumps on the skin or skin like pigmentation, things like that. Different things that might be like, oh, maybe we're looking at this specific syndrome. Multifocal or bilateral cancers. This means like two separate tumors in your breasts, or cancer in both of your kidneys. That may be more indicative that it's hereditary. And then lastly is autosomal dominant inheritance. The vast majority of hereditary cancer syndromes follow an autosomal dominant inheritance pattern, which means that you only have to inherit one mutation, one non-working copy of one of those tumor suppressor genes to have that predisposition to cancer. Recessive inheritance would be if you needed both mutations, one coming from each of your parents. Most of the time with hereditary cancer, we're looking at that one mutated tumor suppressor. So we would see that coming from one parent. And so kind of how you see autosomal dominant inheritance in a pedigree is that, or family tree, pedigree is what you call a family tree, is that like on one side of the family, like grandma had cancer, and then grandma's son and a couple other aunts and uncles over there had cancer, and then that was passed to like this generation, and you have cancer. That's dominant. Recessive is kind of like if we might see features on both sides of the family, or if we just see something like sporadically happen, that's recessive. But typically we're looking for like one side of the family, and like 50% of the children of someone affected also being affected, because if they have that one mutation, there's a 50% chance that they would pass on the mutated copy or the working copy. So like if grandma had cancer, she has that copy, 50% of her kids would get that copy from her and also have cancer. And then for those ones, 50% of those kids. I hope that makes sense. It's a lot. Yeah. Now we have covered all of the like genetics and the basics and what we're talking about here. So now we're going to talk about some of those hereditary cancer syndromes. That 5 to 10% of cancers that are hereditary, that's what we're talking about now, and what that looks like, what those cancer risks look like. I think all of these, most of these, are things that I saw in my rotation. They're relatively common things, but yeah, maybe things that you've heard of. So the first genes that we're talking about are the BRCA or BRCA genes. These are the most common. If you've heard of one, it's probably these ones. Famous because Angelina Jolie has a BRCA mutation. I don't remember if it's BRCA1 or BRCA2, but I think that's kind of how this got well known. But so the BRCA genes are tumor suppressor genes. Specifically, they're genes that repair your DNA when it gets like mutated. And so, yeah, if you have a non-working copy, you're at risk of losing that other working copy and getting cancer. So if you do have a mutation in either the BRCA1 or the BRCA2 gene, that is known as hereditary breast and ovarian cancer syndrome. That's the syndrome when you have one of these mutations, and they are associated with pretty much the same types of cancer, these 5 types of cancer, but they do have slightly different risks, and I essentially like highlighted the ones that have the higher risks. So I don't know if I want to go by cancer type or I'll go by cancer type. So for female breast cancer, the risk with BRCA1 is like slightly higher, 60 to 72%, which is pretty high compared to that 12% risk for the general population. 55 to 69% for BRCA2, which is like ever so slightly lower. Like, I feel like people come in and they're like, oh, I have BRCA2, so I'm good, like I'm not gonna get breast cancer. Not really true. It's like slightly lower. So for both of these, if you have a mutation, you're supposed to start breast MRIs at 25 years old, and then start doing mammograms as well at 30. It's also recommended to consider just removing the breasts because, yeah, get rid of that risk for the most part. There's also a risk of male breast cancer. So male breast cancer happens in about 0.1% of the population. So 1 in 1,000 men get male breast cancer. With a BRCA1 mutation, we're looking at 1.2% or up to 1.2%. So still not very common. With BRCA2, it's a lot higher, up to 7% risk of male breast cancer. So it's recommended to do like clinical breast exams, like just to have a doctor like feel and see if there are any lumps. Most men can't do like mammograms or anything because they don't have enough breast tissue, but there is a risk of male breast cancer. Ovarian cancer is the other big one, higher with BRCA1, 39 to 58%, it is definitely higher with BRCA2 of up to 61%, so much higher with BRCA2. And then pancreatic, up to 5% for BRCA1 and 5 to 10% for BRCA2. So it's not actually recommended to do any pancreatic cancer screening with BRCA1 unless you have a family history of pancreatic cancer. But it is recommended to do it with BRCA2, and that screening would start at 50 years old. So for the most part, BRCA2 definitely is higher risk for men, just because male breast, prostate, and pancreatic are the three that males can get, and those are all higher with BRCA2, so it's definitely worse for men. BRCA1, I mean, a little bit higher risks for women, so probably worse there. Yeah, so it's pretty common actually that I'll see like a woman coming in with BRCA1 and it's clear that it came from her father, and so like it's very, very common for men with BRCA1 to never get cancer, just because we're looking at like 1.2% risk up to 5% risk. Like, it's not uncommon to just fall on the lucky side of all of those risks as a man. So it's common that we'll see like a perfectly fine male pass on a BRCA mutation to a daughter, and then that daughter gets like ovarian and breast cancer. Yeah, so that's also a big thing. Like, this makes so much sense to me, but when I'm talking to patients, I realize that like it doesn't necessarily click that like anybody, regardless male or female, can pass on a BRCA mutation or any mutation, and then it just depends on what organs you have that determine what types of cancer you're going to get. So a male with a BRCA1 mutation obviously is not going to get ovarian cancer. A biological male that doesn't have ovaries, I mean, is not going to get ovarian cancer, but he can pass on BRCA1 to his daughter, and she can get ovarian cancer. So that's kind of a misconception that I see a lot, is like that you can't pass on an ovarian cancer risk if you don't have ovaries, which is not true. You absolutely can pass on that risk to future generations. Yeah, that's the other thing, is like with non-binary or transgender people, it's definitely a big conversation of like your cancer risks depend on what organs you have. You can identify however you want to identify. We will absolutely like call you by your preferred pronouns, preferred name, all of that. If you have ovaries, you're at risk of ovarian cancer. So like it's important that we ask you what organs you have so we know what your risk is. And it has nothing to do with your gender identity. Like, that's totally fine to identify however you identify. But that's the BRCA mutations. We're going to move on now to talking about some other cancer risks with something called Lynch Syndrome. So Lynch Syndrome is like an umbrella condition, and there are 4, or actually 5, different genes that if mutated, they cause Lynch Syndrome. And so these genes are MLH1, MSH2, MSH6, and PMS2. There is another gene called EpCAM that it like forms a dimer with MSH2, so they go hand in hand. And so if you have a mutation in either one of them, it's like the same thing, because then both of them can't work, if that makes sense. So I've never seen EpCAM in the wild, like seen a mutation in it, but like it goes with this one. It's the same risks because they're like, they go together. So yeah, but these genes are all associated with the same types of cancer. It's just that they do have very different risks. And there are actually more cancers than this, which I'll kind of touch on, but a piece of paper is only so big, so so the first one is the colorectal cancer risk. That's really the biggest risk, is colon cancer. It is highest with MLH1, in that like 50% range, and then it goes down with each of these genes, and that's honestly generally how it goes for all of the risks, is that like this is the order in which like highest risk to lowest risk. So like around 50%. With these two genes, you're supposed to start getting colonoscopies at 20 to 25, I think, and then with these it's 25 to 30, I think. Uterine cancer is another risk, specifically endometrial. Typically uterine and endometrial are used like synonymously. Technically, endometrial is like a type of uterine cancer because the endometrium is the lining of your uterus, but I just put uterine because that's what patients are going to tell you is like, my mom had uterine cancer, but it's specifically endometrial. The risks with MLH1 and MSH2 are pretty much the same. When I was writing these down, I thought it was funny because the MSH2 risk, it actually, like, this risk is within that risk, like 34 to 54, and then 21 to 57, like, yeah, that's lower and higher, so I don't know, but pretty high. And then it definitely goes down with these two, but still there. Ovarian cancer has a highest risk with MSH2, actually, which I kind of thought before doing this that MLH1 was always the highest, but not necessarily. MSH2 has the higher ovarian cancer risk, and then here, like, this goes down to the general population risk of 1 to 2%, and like less than 3%, so not very high risks for that with these two genes. Stomach cancer up to 5 to 7 or up to 9% with these higher genes, up to 8% still with MSH6. Stomach cancer, I think, affects less than 1% of people, so being up to 9% is like pretty high risk. And then bladder cancer, 4 to 13% with MSH2, pretty low risks with the others. There is also a risk of like other parts of the urinary tract. It's like the renal pelvis and the ureters. Like other parts of the urinary tract. There's a potential risk of pancreatic cancer. I think it's MLH1 that has the real risk of pancreatic cancer. It's like up to 6% or something. Brain cancer is a possible risk, specifically glioblastoma typically, but there's not like a really quoted risk of that. Skin cancers can also happen with Lynch syndrome. I think that's it. So it's a lot, okay? It's a lot of cancer risks. BRCA sessions are so much easier because I'm like, these are your 5 cancer risks. That's it. That's all you have to worry about. With Lynch, it's a lot of saying like, there's a potential risk of this, so like maybe you should consider doing this, but I don't know what your risk would be. Like, yeah, it's a lot of risks to go over. I just realized there's something else that I want to bring up about both BRCA and Lynch syndrome. So what we've been talking about so far is that mutation in that tumor suppressor gene that leads to the increased cancer risk. There is something that can happen if you have two mutations in one of those tumor suppressor genes. So this would be like if both parents had Lynch syndrome, so both had one mutation, and then had a child, and the child got both of those mutations from them. And that is a big thing we talk about with people when we find that they have a BRCA mutation or a Lynch mutation. So with BRCA, if someone inherits two non-working copies of either BRCA1 or BRCA2, that is something called Fanconi anemia. Fanconi anemia leads to childhood cancers like leukemias, all types of cancer, bone marrow failure. It also leads to all sorts of birth defects like really short stature, issues with the limbs, the fingers, all sorts of things like that. It's a really severe condition. So if we diagnose someone with a BRCA1 mutation, we're always like, if you're gonna have kids, you should probably get your partner tested for BRCA1 just to make sure that you can't both pass on that mutation to a child and get a child with Fanconi anemia. And then the version of that with Lynch syndrome, if a child inherits two copies of one of the Lynch syndrome mutations, that is something called CMMRD, or constitutional mismatch repair deficiency. That's if you have two mutations, and that again causes birth defects and childhood cancers. So definitely something to think about, especially like with PMS2. Like looking at PMS2, it is technically Lynch syndrome. This is technically Lynch syndrome, but these risks are pretty low. Like definitely a risk of uterine cancer, but it's not uncommon to see families where we identify a PMS2 mutation and they have no Lynch syndrome cancers in the family. Like not a single colon cancer or uterine cancer in the whole family. So they wouldn't even know that they had it. So it's a big thing where it's like, have your partner tested for PMS2, because even if there's no cancer in the family, like you don't know that there's no PMS2 mutation. Yeah, so wanted to bring up those reproductive risks. Okay, we have two more big syndromes that we're going to talk about. This one I bring up because it's something I saw a couple times in my rotation, and it's something I sometimes hear on the news. If you are not in the US, then I know that drug commercials are outlawed where you are. But in the US, we have drug commercials constantly, and specifically for Ozempic and maybe for other medications, they will tell you not to take it if you have multiple endocrine neoplasia syndrome type 2. And that's what we're going to talk about. We're going to talk about what that is. So I actually had a patient come in and she wanted to know if she had MEN, multiple endocrine neoplasia, because she wanted to take Ozempic, and she knew that she wasn't supposed to take it if she had MEN. So there is an MEN type 4. I don't know if there's an MEN type 3. There has to be if there's a type 4, right? I don't know. But I've only learned about type 1, 2, and 4. I'm not talking about type 4 here because it's pretty much the same as type 1. But multiple endocrine neoplasia type 1, or MEN1, it is caused by the MEN1 gene. So that's pretty easy. Mutations in the MEN1 gene. And MEN1 leads to what we call the 3 Ps. And the 3 Ps are parathyroid tumors. So the parathyroid is like a gland behind your thyroid gland, I think. And people with MEN1 get presence of non-malignant features. Like, if we're concerned about MEN1, we're not just going to be asking about cancer, we're going to be asking about hyperparathyroidism, something that's not cancer but is characteristic. The second P is pituitary tumors. So your pituitary gland is a gland in your brain, and people with MEN1 get tumors of that gland. And then pancreatic neuroendocrine tumors, or neuroendocrine tumors of the whole, like, gastropancreatic system. But for the purposes of 3 Ps, we say pancreatic. And these are basically just tumors in the pancreas or the gastric system that are endocrine in nature. So they're like in the endocrine cells. So it's different from most pancreatic cancers. But yeah, those are the 3 main features we think about with that one. Yeah. And then with MEN2, multiple endocrine neoplasia type 2, which this one is caused by mutations in the RET gene. So I said earlier that I'd come back to that because RET is an example of a proto-oncogene. So that's what causes MEN2. And MEN2 is associated with medullary thyroid cancer. Close to 100% of people with MEN2 get medullary thyroid cancer. It is very, very common. If someone has MEN2, they are supposed to get their thyroid removed at like 5 years old or before 5 years old, because the risk is so high for MTC. Medullary thyroid cancer overall is like pretty rare. Papillary thyroid cancer is more common, so this is kind of one of those rare cancers that we look for, where if someone has MTC, they should do genetic testing. The next one is, I just hit this, oh my gosh, pheochromocytomas. So I also mentioned that earlier. These are tumors in the nerve cells, I believe. So paragangliomas are tumors in the nerve cells that can happen in like the head, the neck, basically anywhere in the body. Pheochromocytomas are a type of paraganglioma that occurs on the adrenal glands that are above the kidneys. So, type of adrenal gland tumor, and those overall are really rare. So, like, if you have one, again, you should get genetic testing done. And there's about a 50% risk of those with this syndrome. And then lastly is kind of similar, parathyroid tumors, about 20 to 30% risk with MEN2. And you shouldn't take Ozempic, apparently. I don't know why. But yeah, with multiple endocrine neoplasia. I did see, I had patients with both of these, so I have had patients with all of these that I've said so far. Yeah, the last one we're going to talk about is something I have not had a patient with, but it is a syndrome that always fascinates me. So we will talk about, remember tumor suppressors. We're talking about tumor suppressors. They suppress tumors, no way. The tumor suppressor that is like the biggest one that functions in all of your cells is called TP53. It's called the guardian of the genome because it is so important, such an important tumor suppressor gene. And so if that is mutated, if you're born with a mutation in it, that's a big deal. And that is called Li-Fraumeni Syndrome. Li-Fraumeni Syndrome. If you have a TP53 mutation, and because it is such an important widespread associated with pretty much every kind of cancer, and really high risks of pretty much every kind of cancer. So it is not uncommon for people with Li-Fraumeni to have like 5 different types of cancer in their lifetime. It's pretty crazy. I think it's like a 40% risk of getting greater than 2 different cancers in your lifetime with Li-Fraumeni. So these people have to do full body MRIs every year, alongside a ton of other cancer screenings. It's crazy. The risk of cancer overall is higher for women with Li-Fraumeni, and that's because the risk of breast cancer is 80 to 90%. So for a woman with Li-Fraumeni, she's probably going to get breast cancer. Very, very, very common. A big one, so these are like the core cancers, the big Li-Fraumeni cancers, but there are so many others, way more than are on this list. These are just like the big ones. So breast sarcomas, so that's cancers of the soft tissues and bones. Osteosarcoma, yeah, sarcomas of the bones and tissues, up to 30% risk, again, really high. Adrenocortical carcinoma is a cancer of the adrenal glands, again, pretty rare cancer, and it's about 6 to 13% risk with Li-Fraumeni. Typically that occurs in children, so we normally think of like that cancer risk happening in children with Li-Fraumeni. Brain cancers up to a 19% risk. That's pretty high. Yeah, pretty high risk of brain cancers. And then leukemia up to 4%. Those are like the main core cancers with Li-Fraumeni, but again, like I said, skin, prostate, gastrointestinal, which includes stomach, colon, yeah, pancreatic, lung, literally every type of cancer, ovarian, uterine. I didn't write those on here because there's just so many. But yeah, that's why they have to get full body MRIs every year, and like so many other types of screening is because of Li-Fraumeni syndrome. Yep. So that is one that I did not get to see during my rotation. My rotation was only 4 weeks long, so there's a lot of noises going on. There's like a siren. Sorry about that. But I did get to see, I did many sessions with BRCA1 and BRCA2, PMS2, MSH2, MLH1, MEN1 and 2, some others, like, there are other syndromes, like colon polyposis syndromes, and all kinds of stuff, so I got to see a ton of stuff, and it was really exciting. I think I did like 40-something full cases on my own, which was a lot. 40-something full cases. I'm really proud of myself that I did all of that, got through it. Yeah. So I hope you guys enjoyed this video. I know I talked so fast. Sorry about the dog barking and the sirens going off and everything. Birds chirping. It's been a loud day, but I hope that overall it was a good video. I hope you learned something about cancer. I'd love to hear if you have like a cancer syndrome in your family or something, or if you have like a lot of cancers in your family and you want me to assess your risk or tell you if you should go to a genetic counselor. I don't know. But yeah, I love the interaction on these videos. I love when you guys say that you like aced your biology exam because of me. That makes me exponentially so